one of his team for nearly 10 years, is glad to be back and see nice faces back again and back in Jeddah. I'm very lucky that I came just after the talk of Maria, which is, she explained already most of the atherectomy devices in short, or actually extensively in a very good detail, so I'm going to make mine a little bit short. So atherectomy, atherectomy, especially that we were using back in our hospital, is rotational atherectomy. As you're all aware, when we have the endovascular intervention, is either balloon angioplasty or stent. And a balloon, especially in the femoral popliteal segment where there is very long calcification or heavy calcification, the only thing that the balloon do is like more or less a barotrauma, and might end up by flow dissection, flow limiting dissections, poor vessels compliance, and even recoils, and it might need to have a stent deployment later on. That's more or less not treating the artery, it's more or less a detour effect. Atherectomy device is more or less prevent that detour effect. It improves the lumen gain. There is definitely a reduction in the tissue volume, and this is literally very evident, especially those who are using IVUS. They can find that very clear for them. When looking back, I was surprised that atherectomy I thought myself that's all in this millennium, but it's going back to the 1980s, and it's all approved early in 90s, especially with the coronaries, and then started to be into the peripheral lesions, the peripheral vessels. And again, as you're all aware, the directional atherectomy, when they combined with the anti-restenotic therapy, which is the DART, that gives a very good modality of treatment. Definitive study by Professor Ziller in 2017 definitely demonstrated a very good technical success and long-term patency. Also in the common femoral, which is the gold standard, would be the endarterectomy surgical. But even on a study done on 30 cases, they showed that atherectomy together with the DCB tool have a safe and a good effect compared to the surgery. There are different types of atherectomy devices. I believe it's all explained and thorough. What we're going to discuss is more or less the rotational, which we use mainly back in our hospitals. Again, the same slide. When we talk about which is preferable, I couldn't find that there is certain atherectomy devices better than the other, and that unless if there is some certain points. For example, if we have a previous stent, I don't think that directional atherectomy would work nicely in that situation because it might stuck into the struts of the stent. But looking back at this study they found out that directional atherectomy may be superior to the orbital atherectomy. This is more or less a limited study, but this is what's seen in literature. Again, this is the Mr. Ziller, Professor Ziller's, when he came out with that, a good effect of DCB together with the rotational atherectomy. Good technical success was found. It's gone viral in the States, 2016, that all the Medicare that found out that 1% of the peripheral vascular doctors get most of the money all the way down because of the use of the atherectomies. It's definitely a costly device that's been used virally, and even in the lower limbs, more than 90% of the money that goes to the angioplasty in the lower limbs is more when there's when atherectomy device is incorporated into it. On the other hand, Cochrane follow-up did not show that much of that improvement, but definitely there is much less in the stent deployment needed when we use the atherectomy device. There is no modality that's out of complications, but there is some complications, and I believe Professor Masad Suleiman is going to more or less explain in the next session about the distal embolization, but there is risk of distal embolization from 5% and some estimated up to even 12%. Guide wire entrapment, especially when we used it in the rotational atherectomy, we find that it wasn't that common, but it happened in some of the cases, and we had to take the whole system out. dissection, though that the bailout the bailout stent that needed afterwards, not that, or that's the aim of the directional atherectomy, is to reduce that stent deployment, but actually using the IVUS did raise that concern that there is dissection is more than we even thought. Pseudoaneurysm, as seen in the pictures, I don't know exactly which one is more or less that, less likely that would be with the rotational. When we use the stents is good, but still 1/3 of the cases in 1 year, they can develop with in-stent restenosis, and half of them in a 2 years' time. Combining the modality, again, with the atherectomies and DCBs might be a very good solution to improve the patency and TLR reduced. And this is all by trials that's done by Jetstream and Jet and Excite lasers. These are the number of cases that we used back in St. George's, South London, in the year 22-23. And most of the cases, more than 20-something that was done in the femoral and popliteal artery, and most of them was successful. When you can see even those who weren't able to do is more or less those without the stent. That's due to the wire did not go through the true lumen, and this is the most important trick when we're using directional atherectomy. We're going to present some of the cases that we did in these 2 years. So this is a 78 years old male that's got all the complications of the classical vascular patient, ischemic heart disease, and actually he was waiting for have a cabbage, poor ejection fraction, diabetic hypertension, poor kidney functions as usual in the AF. He actually had a previous stent in his SFA, and during the surveillance we found out that common femoral stenosis, and they were concerned about whether this can go down this stent. So this patient had previously actually intravascular lithotripsy for his common femoral, and you can find that chunk of calcium very evident with that stenosis, that more than 75% stenosis and high PSA. This is after the atherectomy, and you can notice on the left side of the images where the flow has much improved in that common femoral. Again, the classical would be in some centers, and even most of us agree that common femoral endarterectomy surgical would be the more appropriate for him, but because of his comorbidities, that wasn't capable to do for him safely. Another case is with a very long stents in the SFA, and unfortunately they gone down, the patients returned back. Some of them had like short distance claudications disabling him, or he presented with CLTI, and the option is either to do the bypasses or to do an angioplasty. As you can see, the stent starting from the common femoral, just from the origin of the SFA all the way down to the popliteal. And again, we managed to cross with the wire interluminary, which is the most important trick and most important point, where to go all the way down to get into the true lumen, and then use the directional atherectomy all the way down, and then followed by DCB. Another case from different interventionists, all the way managed to get interluminally all the way down, then followed by DCB with a very good results. Sometimes the stents are so difficult to cross, which is, on the other hand, would be a benefit to go into the struts, get into the struts and get retrograde all the way up, and then try to cross back again into the true lumen, and then use again rotational atherectomy. In the popliteal, again with a good safety outcome. Still, some cases we did have some sort of distal embolization. We used around half of the cases we did have to do still there was distal embolization, and we managed to get it out during the procedure with various suction thrombectomies. In conclusion, to cut short, rotational atherectomy is safe and treatment modality. We have to use it safely when it's combined with the DCB. Satisfactory results, as shown in here, in in-stent restenosis was a really good outcome. Again, there would be a complication every surgeon or every intervention should be aware of, and it needs a long-term follow-up to see how's the effect of intervention modality like that. thank you all, and thanks for the team at St. George's. I appreciate it. Thanks.